COVID Avengers, this is our team. The United Nations has adopted the One Health model for disease prevention, which recognizes that animal, human, and environmental health are linked. Our 5 recommendations are based on this model. There is a severe health disparity between urban and rural population. COVID mortality rate was found to be 13% higher in rural dwellers after controlling variable factors. Globally, almost half of the population live in rural. Therefore, our recommendation is to ensure equitable and adequate healthcare access by promoting telehealth network. One major obstacle of this strategy is the inadequate broadband access in underdeveloped areas. However, Medicine Healthcare, which is the largest rural health provider in the state of Michigan, has provided us with a successful example, showing that it's financially rewarding and sustainable to invest into broadband infrastructure and develop telehealth program. We therefore suggest a national-wide telehealth program for rural hospitals and family doctors in each country.
One major barrier to health and equity in pandemic prevention is lower vaccination rates in Indigenous and national minority groups, such as in the UK, where the Black British group has a 10 to 20% lower vaccination rate for both standard vaccines and the COVID-19 vaccine. Our recommendation is to empower leadership in Indigenous and minority groups and to develop vaccination campaigns led by these groups to combat vaccination hesitancy. Barriers to increasing vaccination rates include complex issues involving misinformation, mistrust, and structural and systemic inequities. Our recommendation aims to target these barriers. Maori are the Indigenous people in New Zealand. An approach encouraging Maori-led vaccine campaigns and healthcare has been implemented in New Zealand. From August 2021 to December 2021, it successfully reduced the first dose rate gap from 40% to only 9%. Implementing Indigenous and minority-led campaigns will help increase vaccination uptake and therefore prevent the next pandemic.
A further barrier is unequal disease surveillance capacity. Reduced capacity in poorer nations reduces their ability to stop early outbreaks, leading to higher infection rates and disproportionate burden on local and regional healthcare systems. The Global Health Security Index reports that only 37 countries can consistently maintain disease surveillance infrastructure, costing millions per year. To tackle this inequality, we recommend enforcing international surveillance data sharing and open source research for treaties involving countries and regional disease prevention bodies like the European or African CDC. This system has already found success in existing agreements for influenza prevention, which was critical in limiting the spread of the H1N1 pandemic. They mandate that non-compliant parties cannot benefit from related research, incentivizing them to contribute. By expanding these principles to more infectious diseases, we can use international partnerships to ensure all nations have equal access to the tools of pandemic detection and thus prevention.
Every year, there is an average of 2 new viruses brought from their natural hosts into humans. This includes but not limited to SARS, H1N1, and COVID-19. The risk of virus spillover is higher than ever, driven by the unprecedented loss and fragmentation of forests and burgeoning wildlife trade. People who live at forest fringe or in contact with wildlife are at particularly high risk. In light of that, we strongly recommend all countries to reduce deforestation and phase out wild animal trading. One major obstacle is the potential financial loss. However, a recent study investigated successful examples of deforestation prevention and found that its financial gain far outweighs the cost. And this does not even include the benefit of preventing the next pandemic and saving lives.
Poor health literacy contributes to health inequity as the population groups with the lowest health literacy are also known to have the poorest health outcomes, particularly in pandemics. Our recommendation is to integrate public health knowledge and pandemic prevention at all levels of the education sector. For example, incorporating mandatory awareness of disease transmission at primary and secondary level science and training health science students in vaccination and disease control. One challenge of this is that it relies on individuals' ability to access the education sector. Similar programs have already been successfully trialled in sub-Saharan Africa during the ongoing HIV pandemic. This solution would reduce the social determinants of health faced by less health literate populations in the short term, as well as increase population-wide preparedness for incoming pandemic outbreaks.
In conclusion, the 5 strategies that we presented to you today will help reduce the impact of any future pandemics. These include promoting a nationwide telehealth network, empowering leadership in minority groups to promote equity in vaccination, regional collaboration for pandemic prevention, reducing deforestation and wild animal trade, and investment in health education. Thank you so much for listening.